Hello, good morning. So, in next couple of minutes, we will be taking care of common cases, but what a pediatrician should know, what are the basic things what we have to follow, and that is what our focus is going to be. Okay. So, this is a 2-year male child who was previously normal, weighs 12 kg, grown well, started with fever for 3 days and also cough for 3 days, consulted on day 2. Symptomatic treatment was given by pediatrician. On third day, that was yesterday, the child has become, the fever is persistent and he has become breathless. The intake has gone down. There is only one urine output in last 12 hours and he is quite irritable yesterday, and today is very, very dull. So he has come to you. And I'm sitting in my OPD. I don't have any monitor. I don't have any ICU facility. So my question to Dr. Shivprasad, is this child sick and how are you, how do I assess? I don't have anything in my OPD.
Thank you. Looking at the case that this child is 2-year-old and all red flag signs are present. Symptoms and signs are red flag signs are present. Child is breathless. Child has not passed urine since 12 hours. Child is irritable. So it's a serious case and we should refer this child. According to INMCI also, this child falls in as a severe disease.
Perfect. So this patient has been rightly picked up by the pediatrician, referred to a hospital, but it still doesn't have a PICU facility. So this is the level hospital, second level hospital, and they have checked his vitals. He's drowsy but oriented, heart rate of 190, BP 85/50. Okay for his age, but he has cold extremities. Saturation is just 60% and respiratory rate of 70 to 80, lever of 3 centimeters. Does this information adds to anything, Dr. Shivprasad?
This child requires ICU care and this child is really in a bad shape. SpO2 is 60%, means he will require an oxygen. Though BP is still normal tensive, but anytime it can go in hypotension. So this child should be, rescue fluid should be given, rescue antibiotic should be given, and this child should be referred to an ICU with proper care in ambulance.
Perfect. So by pulse definition, we'll call this as respiratory distress with a normotensive shock. Now, my question to Dr. Sandipan. We want to transfer this case from this nursing home to a PICU, and I have various oxygen delivery devices with me. I have prongs, mask, NRM. How do I transfer this child?
For sick patient, maximum crashes occurs during transportation, because in peripheries or in our districts, the transportation takes times because of roads and all those things. So transportation is important here. The transportation, whatever ambulance we are using, the ambulance should be equipped with oxygen as well as with monitors. Here the saturation is on lower side, so I will like to use oxygen. Two types of oxygen delivery devices are there, low and high flow. Here I have to go for high flow oxygen devices like non-rebreathing mask with oxygen reservoirs, because here we can achieve 100% oxygen with this reservoir. As well as already we have secured the IV line. So during transport also I will give fluid bolus first and reassess the child.
Perfect. How much oxygen you want to start with this NRM? 5 liters, 10 liters?
More than 5 liters of oxygenation we have to start.
Yeah, so we'll start with maximum possible. Our normal flow meters give up to 15 liters. So we'll start with 10 to 15 liters of oxygen, which will give higher concentration. Perfect. So this child was started with non-rebreathing mask. Saturation was achieved to 90%. IV access has been rightfully established. Sugar was 45. This has been corrected. Labs have been sent and the first blood gas shows metabolic acidosis 7.12, bicarb of 12 and lactate of 3.5. Heart rate is still 180, respiratory rate is still 70 and distress is present. So this patient is now being referred to higher center with PICU facility. And Dr. Ashutosh, how are you going to transfer, and please enlighten us what is the correct way of transferring this patient?
Most important thing is a clear communication between the person who is transferring to a PICU and consultant at PICU. what all should be discussed is a clear communication will be like S-bar. What is S-bar is you must explain the what is the situation, what is the background behind all these things, what has happened, what assessment at the primary center from where child is getting referred, and what are the recommendations you are going to give to a referring physician. Important thing is confirm the bed at PISU facility as well as explain the cost of the
Yes.
this PISU care at referring center. If both things are told in hand, then it will be a good transport. Patient should not have a crash landing at PISU facility. That will be a catastrophic thing from patient care of as well as from economical point of view.
And also in this situation, confirming the availability of a ventilator.
In this situation, as sir already has spoken, at least 10 liters of oxygen with non-breathing mask, IV line should be secured and patient should be referred. HFNC can also be started during the ambulance if facility is there.
So this child has been now rightfully being transferred to higher center, and it has reached to Dr. Sachin. And now we have to, so is there any NIV, use NIV, CPAP in our neonatal age group, or do we really use NIV in pediatric age group at 3-4 years of age?
Yeah, looking at the progression of this case, till now we have just supplemented the oxygen. But we have to focus on the underlying issues like this child may be having some bronchiolitis or pneumonia. Then he needs more than oxygen, he needs pressures to open up his lungs. So NIV is a bridge between the, or it fills the gap between that endotracheal intubation. So it is a form of the ventilation where there is, we avoid endotracheal intubation. So the modalities which are available with us are HFNC and CPAP and BiPAP. Because of interference, these are the various types of interfaces, but we commonly use HFNC because it is easy to use and patient friendly. The other ones are means a patient take a lot of time to get adapted with these nasal pillows and helmets. So HFNC is a preferred mode of NIV, and this can be used during transportation also. So HFNC is the preferred mode for NIV in our setting also.
Is there any contraindication for using HFNC or NIV at this point of time?
Means if the patient is having altered sensorium, his respiratory drive is altered, he's having GI bleeds, or he's in a state of a cardiac arrest or pulseless shock. So these are the contraindications for NIV.
So as rightly put, severe respiratory distress or hemodynamic instability or poor sensorium, all these things are in fact contraindications for NIV. But even at a tertiary care hospital where you have referred this patient, intubating a child in ER is always going to be dangerous, critical situation. So we'll talk about it. So before you arrange everything, you can still start with HFNC by half an hour and then do the needful. Okay, my question to Dr. Sachin again. We have decided 2 hours down the line, with this child needs intubation. Heart rate is still 155, RR is little bit less, but this time now he has become more and more drowsy, and we have repeated the gas. pH is 7.05, bicarb has fallen down, lactate has gone up. So acidosis is worsening. So couple of questions: how are you going to intubate this child, and how cuff tube, non-cuff tube?
So whatever intervention we have done with HFNC, we try to open up the lungs by giving support and oxygenation. But still the patient's condition is worsening. He is becoming drowsy, and his gases are becoming he's having severe respiratory acidosis. In this situation, definitely we have no option but to intubate this patient. Now, intubation in this patient is the major task, or the time where there can be a major catastrophe can happen. So we call it as a resuscitative intubation. So we have to be prepared for intubation in such cases. So what kind of preparation we need? We should have age appropriate endotracheal tube. Now these cuff tubes are preferred for endotracheal intubation, and the formula for this selection of tube depends upon the 4 plus age divided by 4 for uncuffed. For cuffed one, 3.5 plus age divided by 4. That is one thing, and another thing is another part of preparation is the sedation, analgesia, paralytic agents, and assessment of vascular status of this patient. So we need to give fluid boluses, start inotrop, and pre-oxygenate the patient before intubation. So what are the ways to pre-oxygenate this patient is you can apply non-rebreathing mask at least for 5 minutes, 5 to 10 minutes prior to intubation, so as to achieve the oxygen level up to 100%. Or whenever the patient is apneic, we can give bag and mask ventilation in such scenarios. So I would like to use cuff tube in this patient.
Which medications you would avoid in this situation for intubation, and which one you would prefer?
Since this patient, I would like to use sedative agent like ketamine because I'm using a shock, and atropine I would like to use because there is a chances that this patient may go in a vasovagal shock and bradycardia.
Yes. So this patient is using his sympathetic drive to maintain his hemodynamics. The moment we sedate him with midazolam or propofol, this child, the sympathetic drive will be off. There would be no blood coming to the heart, and the cardiac output will fall, and the patient will go in arrest. We have seen this n number of times. What is very important is to prevent this. So as rightly mentioned by him, we'll start a fluid bolus, let it go on. Even in the smallest of the centers, you can start dopamine infusion. If not, the best would be adrenaline infusion to go on. And no propofol, no midazolam, atropine definitely a good agent till 2 to 3 years of age, and ketamine. These are my agents of choice. Perfect. So this child, the reports have come. Hemoglobin is 10, total counts of 27,000, neutrophilic predominance, CRP is 200, blood culture is sent. And considering this as a community acquired pneumonia, we have started him on ceftriaxone. This child, 10 ml per kg NS bolus was started, and after that intubation was done successfully, safely, and then after that the BP and pulses both have improved. So primary, now we are left with respiratory distress on ventilator. So I have started with him on PRVC mode, so 6 ml per kg, respiratory rate of 25, FI to 100. Initially started with PEEP of 6, 8, 10, went up to 10 to achieve 100% saturation. After 2 hours, lines have been secured, heart rate has come down to 150, pulses and perfusion is better, urine output has started coming in, and pH is also better. Lactate, which was 6, has improved to 2.5, and bicarb, which was 8, has improved to 14. Peak pressures are 35, MAP, that is mean airway pressures, are 22, and my PF ratio is 95. This time the ABG on 100% oxygen shows PaO2 of 95 on 100% of FiO2. Now my question to Dr. Shivprasad is this LRTI or is it ARDS, or is it both, and what is the difference?
This appears to be LRTI going towards ARDS. Difference between LRTI and ARDS is the severity only. To start with, any LRTI can become ARDS, but there are many causes for ARDS. So any case of LRTI can go towards ARDS. What was your next question?
Yeah, and how do you define ARDS? Is there any simple guideline to remember?
Yeah, there are different definitions from PF ratio to SF ratio. Recent definition for PARDS 2015, as we see on the slide, mild is by saturation by FiO2 ratio less than 2 to 264, oxygen index 4 to 8, and OSI 5 to 5.7, 7.5. When we label this, we can straightway say whether it is a moderate or a severe cases.
Yeah. So very rightly mentioned, PF ratio was conventionally used, that is PaO2 on gas to the FiO2. However, every time ABG with PaO2 may not be available. So even saturation is good enough to call as a ARDS definition. So they have included this SF ratio. Also, as neonatologists have been traditionally practicing oxygenation index, which has been found very useful to assess the severity of hypoxemia, this also has been incorporated into this PARDS definition. Okay, so my question to Dr. Ashutosh is, what are the ventilator settings for this ARDS, and please explain what mode, what tidal volume.
Most important thing is to maintain the adequate gas exchange without causing lung injuries. So mode, regarding mode, any mode is fine, perfect, as long as you are comfortable with that mode. We limit the tidal volume to 4 to 6 ml per kg. That is the best thing and has a survival benefit. FiO2 we keep at less than 60% because oxygen toxicity can again damage the lungs. Important thing another is I ratio. Inspiratory phase we almost keep it as same as expiratory phase, and PEEP titration. PEEP titration is important to open the alveoli.
Which mode your unit uses?
The mode which you are comfortable with. Any mode is fine.
So Dr. Ashutosh, what is this optimum PEEP? Everybody talks about optimum PEEP. I want to really understand this.
Optimization of PEEP is the PEEP which can generate the maximum oxygenation with minimum over distension and has a best compliance. That is important thing.
So if I'm using a pressure mode or volume mode, how do I assess that? What is right PEEP?
In pressure mode, we'll keep on increasing pressure as long as the saturation is maintained, and at one point you won't see this increase in saturation. In fact, child may have desaturation. That is a point where you should limit your increasing pressures.
Absolutely. So on pressure mode, we start increasing the PEEP, and the tidal volume will start increasing. The FiO2 will start also improving. But after you have achieved your optimum PEEP, if you still go on increasing by 2, 2, 6, 8, 10, 12, 14, the saturation will fall and even the tidal volumes will start falling. So the tidal volume at maximum tidal volume achieved, maximum oxygenation achieved at that PEEP is optimum PEEP. Whereas on volume mode, the difference is the minimum PEEP achieved is the right mode of right PEEP. Okay, so we have gone up to PEEP of 14 and then the patient is stabilized now, 100% oxygen we were initially on. We have started coming down FiO2, we have reached up to 70%. So how many days I can keep this PEEP, or I have to start reducing it? And if yes, what is the problem with this excess PEEP?
Ideally, as long as the thermodynamics are not compromised, we can continue, but soon we should come down to a lower PEEP because again over distension will cause lung injuries.
Absolutely. So the right PEEP of 14 yesterday will become excess today, and that will also compromise on capillary perfusion, cardiac preload. So we should start reducing this slowly. So typically 6 to 8 hourly we reduce PEEP of 1 as tolerated. So Dr. Sandipan, the nurse is complaining that each time she goes for suction, the patient desaturates to 50. What should you do? What should she do?
See, for suctioning, you should not tell sister that every 3 hourly, 4 hourly you have to suction. Because the simple formula is if secretions are there, then do the suction. It's not that 3 hourly, 4 hourly we have to go for it. And preferably nowadays we have to use inbuilt suction with endotracheal tubes with inbuilt suctions are available. So I will like to use that. As well as while suctioning, if you are using ambu bag, then that ambu bag, nowadays ambu bag with PEEP are available. So preferably we have to use that because during suctioning also that we can generate the PEEP. And even if after doing this, if patient is desaturating, then in that case we have to use recruitment maneuvers here.
How will you do that?
Recruitment maneuvers, we have to increase PEEP by 1 or 2 centimeters and assess the child, and during assessment if saturation is improved, then stick to that PEEP for like 30 minutes, and once patient stabilized, then try to decrease the PEEP.
Perfect. So Dr. Sachin, recruitment maneuvers, and can you explain what is this proning?
basically now, since we have labeled this case as a ARDS, and as we know, the pathophysiology of ARDS is a heterogeneous lung disease, where are certain alveoli which are collapsed, and there is affection of this vascular flow across this thing. There is a V2 mismatch is there. So there are certain alveoli which are although functioning, but there is no flow across these alveoli, and there are alveoli which are collapsed, but there is a blood flow across them. So in recruitment maneuver, we focus on opening those alveoli. We call it as a functional recruitment, wherein we just try to give pressure for certain amount of time and make those alveoli to distend so that we can improve the oxygenation. There are various methods like 40-40. So we give pressures of 40 centimeters of water for 40 seconds. These are the brief recruitment manuals. And one of the time tested and now proving to be very effective in management of ARDS is prone positioning. It is also one of the kind of recruitment manual, because previously when we used to ventilate the patient in supine position, the alveoli which are in the dorsum of the lungs were not getting recruited, and we are not actually targeting the basic pathology of ARDS. But since we have started ventilating patient in prone position, as we are seeing in this figure, these dorsal alveoli are collapsed, and after toning, if you look at, they become in a ventral position and they get distended. So it helps in improving this thing, perfusion and ventilation, this thing. And usually in prone positioning, we keep patients for around 16 to 18 hours and 5 to 6 hours in a supine position. Now, during the treatment of ARDS, we should not change the saturations. We have to think the side effect of the ventilation or the high pressures which are given. And due to this, to reduce the ventilator-induced lung injury, we have to accept the certain numbers which are not in physiological range. So for that, the concept of permissive hypoxia and permissive hypercapnia has been tossed. So basically, permissive hypoxia is accepting the saturations of 92 on the pulse oximeter and oxygen PaO2 of 60 and with pH of 7.2. And permissive hypercapnia is accepting pH of 7.2 with PCO2 of 60 to 65. Basically, it is intended to reduce the ventilator-induced lung injury.
Yes, Dr. Sandipan, question for you. This is child on ventilation. What sedation, analgesia, paralysis, what all infusions you want to start?
Regarding permissive hypercapnia, once patient is stabilized, patient is out of shock, so we should not go behind improving the SpO2. Once we achieve SpO2 of 89, 90, then we try to decrease FiO2 to achieve permissive hypoxia. So during ventilation, it's not that everything will be easy, because during intubation also we have to use some sedative agents like fentanyl, and we can use midazolam intermittently. Yeah.
Correct.
And if VQ mismatch is there and synchronization is not there with ventilation, then that time you can use paralytic agents.
Absolutely. So this child was ventilated for 8 days. There was a slow but sustained recovery. We extubated him on day 9, and again off oxygen for day 14 and then discharge. But had he not improved, one thing what I want to highlight today is the option of ECMO. ECMO is just like a prolonged bypass where we give organ support to 2 organs. If it is veno-venous ECMO, it is a respiratory support. If it is veno-arterial ECMO, then it is heart with or without respiratory support. It can be given for 5, 7, 10 days, and then since you are kind of bypassing both these organs, you are allowing them to rest. This is the whole idea behind it. So in summary, identify respiratory distress. You don't need a monitor for that. Oxygen devices are available, but while transfer or for any sick patient, focus on non-rebreathing mask or We also spoke about high flow nasal cannula. Resuscitative intubation, absolutely important topic. Everybody should go and see on YouTube. We also looked at ARDS definition. We looked at ventilator strategies, and one important device is AMBU with PEEP, because that can prevent desaturation during this ventilation. Okay, moving on to case 2, we have 5 minutes more. So this is a 4-year girl with history of fever for 3 days. She's afebrile for last 6-8 hours. She had 4-5 vomitings. Yesterday abdominal pain was there. Today she's oriented but very tired, prefers to sleep. Urine output only twice in last 24 hours. Heart rate is 170, cold extremities. Again, I don't have a BP machine in my OPD. Peripheral pulses are not felt. Respiratory rate is 50. There are no crepitation, no wheeze. She's oriented but little drowsy. In the OPD facility where actually NIBP is not available, what I can do and how do I assess this child?
When NIBP or any facilities are not available, we can assess clinically by the cold extremities, CRT, pulses, volume of the pulse, and sensorium, urine output. We can straightway label that this case is in shock.
Absolutely. So after once you label this,
once we label this
what
as
are you
a
going
shock,
to do?
now we are in an OPD setting, but we should give a bolus for this patient as we should secure ABC, bolus, antibiotic, and oxygen. Means oxygen, bolus, and antibiotics should be the pocket.
Very rightly said. So NS bolus was started, sugar was checked, it was normal, and then this child was referred to a PIC facility. Here is heart rate 170, BP is low, 70/50. So what pulse definition you want to use at this point of time?
For this age, this child is in hypotensive shock, and this need an ICU care for this child.
Absolutely. So ABC, as he mentioned, we have done that. Lactate of 4, bicarb of 10, this is the blood gas. So there is metabolic acidosis. Dr. Ashutosh, we want to give now fluid boluses. How much you want to give? 10 ml, 20 ml, up to 200 ml per kg? What should be the line?
To start with, we'll give 10 ml per kg bolus. We'll assess what are the changes in the heart rate. If heart rate is improving, we'll continue with the same. If heart rate deteriorates, need to adjust again. If with first 10 ml per kg, child has not improved, we can go with another bolus, can go up to 3 boluses.
And we also have a UAG in this facility. You can see in this thing. Any interpretation?
Contractility is good. IVC is still collapsing. Can go with another bolus for this child.
Perfect. So you have completed 3 boluses. Heart rate has reduced a little bit. Peripheral pulses are still feeble. CRT is 3 centimeter. Now, Dr. Sachin, what do you want to do? Give extra bolus, colloids, inotropes.
Yeah, looking at the current assessment after giving initial 3 boluses, this child is still having tachycardia. His extremities are cold and he's having narrow pulse pressure. So definitely by categorization of shock, we look at preload, afterload, and contractility. Now we have assessed initial this 2 factors of this patient. That is, we have looked at the preload. That is, we have given a fluid boluses, and we have assessed the contractility also. So contractility is good. So what remains is your peripheral vascular resistance. So in warm shock, there is a vasoplasia, and there are bounding pulsations. Extremities are warm, and CRT is brisk, although the patient is in a state of a shock. In cold shock, there is a low preload situation, but there is high peripheral vascular resistance because of catecholamine, and there is a low cardiac output state. So the preferred inotropes nowadays either epinephrine or norepinephrine. So epinephrine is considered in a scenario of a cold shock where you are having narrow pulse pressure and cold extremities. We tend to start with 0.05 microgram, and we can go up to 1.5 microgram. But preferably we have to get the central access as early as possible, or we have to look for the central access to give these inotropes. There are various inotropic agents like dopamine, dobutamine, which are having various actions on alpha and beta receptors. But nowadays only 2, adrenaline and noradrenaline.
Absolutely. And one more thing to remember is both adrenaline and noradrenaline can be safely started from a peripheral line. There is no necessity of or a condition of putting a central line right now. Just dilute them adequately and don't mix with any other IV fluids or anything else. But it can be started and then you can secure in next 1 or 2 hours your lines.
Yeah, and colloids like we have very limited options like hydroxy with starch and 5% albumin. Only 5% albumin is indicated in dengue shock syndrome. Otherwise, colloids we don't use frequently. And for steroids, like if the child is having underlying immunocompromised conditions or he is on steroids, and we have to label it as a catecholamine resistant shock, then only we can consider steroid. Yeah.
Yes. So, Dr. Sandipan, what antibiotics?
This is sick child, and child is requiring boluses as well as child is requiring inotropic support. So first we can consider using broad spectrum antibiotics. Like straight away I can go for meropenem also, because this is a life-threatening situation here. And once I get the reports, then I can step down also. As well as during assessment, I have to assess that if child is having some respiratory illness, as well as if there is history of any urinary tract infection, that simultaneously I have to assess it.
So we'll start with higher antibiotic, and once we have cultures or the other information, we'll downgrade. So this child, after 4 hours, we have got the labs. He's dengue NS1 positive. So we have downgraded his antibiotic, but still continued ceftriaxone considering his overall sickness. There is also a component of hepatitis. OTPT is high, however, INR is maintained. At the end of 3 years, 3 boluses have been done. Albumin has been started, adrenaline started, and the lactate and bicarb both have still worsened. So we are on inotrope started, fluid optimized, albumin started, antibiotic given, but still he is not doing well. Now what? We have decided to intubate this patient. We have done it properly. And my question to Dr. Sandipan is, why did you ventilate this child? There was not much of respiratory distress. There was only shock. Why did you intubate?
We try to treat the shock with fluid boluses as well as with inotropic support, but still ABG is worsening. We are not able to. We have corrected the shock, but this time I like to decrease the work of breathing also, as well as I like to decrease the afterload. So that's why I have to electively ventilate this patient, considering all his critical condition.
So ventilation is also called as inodilator for left heart. It helps your left ventricular. So in case of resistant shock, you will intubate this patient. Okay, so after 16 hours, adrenaline has been going good and he is doing well. Urine output is better now. BP is better. My question to Dr. Ashutosh is, what fluid strategy? We have given 3 boluses. Now we want to resuscitate this child.
As we can see that X-ray is showing bilateral effusion, liver is coming, effusion is also there, but most important thing is urine output has improved. Most second highest blood supply goes to the kidney. So if urine output is very good, that means all organs are well perfused. So we can cut down with the fluids, and while even we can stop if child is feeding well, or through RT if we can feed the child well.
Yes.
Another thing is if fluid overload, signs of overload are there, then we can even give diuretics as a continuous infusion also we can start. So we can stop at our will.
So very rightly put, once the dengue shock has resolved, the perfusion is better, the BP is better, the CRT is better, which may happen 6 or 12 hours from the initial point. There is no further point of giving 5 ml per kg, 7 ml per kg. You can straight away shift to maintenance fluid, and you can also start low dose diuretic infusion, because initially 10 years back we spoke about shock. Now we are treating and we want to prevent the overload situations. Okay. So at 48 hours, adrenaline has been stopped and patient has been extubated safely. He's doing well and he's been shifted to ward. On day 4, the fever starts and the central line is still in situ. He was also catheterized, it's urinary catheter, but it has come out. So what is the problem now? Heart rate again gone up, fever is there, he looks toxic. So Dr. Shivprasad.
Looking at this condition, the child was in ICU, ventilated. This appears to be a ventilated associated pneumonia or any hospital-acquired infection, or it can also be an HLH. We have to look for the all parameters, clinical as well as investigative parameters for this child.
So very rightly said, and we checked his CBC, hemoglobin had dropped, total counts also have dropped to 1500, liver enzymes have gone up. So we checked his ferritin was 30,000, LDH high, fibrinogen low. All in all, bone marrow done, suggestive of HLH, started with steroids. After 5 days, the child recovered and was sent home. So take home message, shock, early recognition is very, very important. We don't need monitors for that. Clinical assessment is absolutely adequate to diagnose the state of shock. Number 2, I know the starting therapies, oxygen, IVs, securing boluses, taking a culture, firing an antibiotic is very essential and can be done even in OPD setup. USG plays a very important role for diagnosing and optimizing fluid, and it is now routinely available in all tertiary care ICUs. Dengue shock treatment, clarify your targets, accept low BPs and avoid overload. Finally, de-resuscitation is a very important word being used now, all kinds of shock, be it dengue or even septic shock. And we also use low dose diuretic infusions. And finally, I'm sure we all have seen n number of HLH in last 6 months of dengue. Thank you.
Thank you, sir. I sincerely thank all the dignitaries for this brainstorming session full of zeal. I now request our chairperson to kindly felicitate our